One of the most interesting conditions of circadian rhythm problems is completely blind people. And we know from the 1970s that they may not be able to live on a 24-hour day. And this is because they, with complete blindness, including light that you don't perceive but which still gets through to your brain, in complete blindness, people's internal systems do what's called free running. That is, they deviate from 24 hours. And most people deviate longer than 24 hours, so that if you study the circadian rhythms of a blind person, you'll get an average period, not of 24 hours, but of 24.5. This means that every day is 30 minutes different. And every so often you run completely out of phase with the normal 24-hour day, and you want to sleep in the middle of the day, and you wish to be awake in the middle of the night. It's like having jet lag every so often for the rest of your life, and nothing you could do about it. And for some people this is really debilitating. And immediately after our jet lag study was published, I was phoned up by a blind man called Harry Kennett. "Oh, Dr. Arendi," he said, "I see that melatonin can change circadian rhythms." He said, "I'm a blind man and I can't live on a 24-hour day." I'm not sure what his exact words were, but essentially he self-diagnosed 24-hour circadian rhythm disorder. Could I have some melatonin? Well, we weren't just going to feed it like sweets. We said, "Will you do an experiment, please?" So we did a placebo-controlled, double-blind crossover on this one guy. And we did a month on placebo, followed by a month on melatonin. And within 4 days of switching placebo to melatonin, he rang up and said, "It's like night and day. It is like night and day. It's wonderful. At last I can sleep at the right time." And he was on it for the rest of his life, which was long.
So there's still a lot of controversy around antidepressants and the treatment of depression and whether these compounds actually show any efficacy. But that takes me back to a period in my life where I'd moved to America and my wife and I were looking at an apartment to buy. The lady who was selling the apartment, we wanted a 3-bedroom apartment. The lady who was selling the apartment to us asked me to sign the contract, and of course you have to sign your occupation. So I put something down like neuroscientist, and she said, "I can't thank you people enough." She said, "Are you involved in drug development?" And I said, "Well, yes, I have been." She said, "Well, do you know anything about a compound called Seroxat, Paxil?" I said, "Yes, I did, having worked 10 years on the compound, but I didn't mention that to her." She said, "Well, you people have given me back my husband, and he'd been an actor on Broadway for many years, and unfortunately he suffered from depression, or has been suffering from depression. Seroxat has given my husband back to me following treatment with Seroxat. So I can't thank you enough, but would you sign this other contract for me?" So I thought, sign another contract? She said, "This is for a 2-bedroom apartment." She said, "I know you want a 3-bedroom apartment, but this is for a 2-bedroom apartment. And as soon as you walk in, you'll fall in love with it." So my wife and I said, "Okay, fine." So we go down, open the door, and walk into this 2-bedroom apartment. And there before us was a huge window expanse which overlooked the Hudson River and the view of Manhattan and the Empire State Building. So we fell in love with it. So that is one of a number of people that have come to me over the years and said, thank you as a neuroscientist for helping me with my depression.
At the clinical level, one experience that stood out from my houseman days, we admitted patients usually overnight, and then in the morning we had a ward round with a consultant, and I was talking about this young African boy who was about in his teens, and he'd come in, and I said he was extremely uncooperative. He wouldn't open his mouth. I couldn't see what his throat looked like, and I couldn't examine his abdomen because he was very uncooperative and wouldn't relax, and so on. And then the consultant looked at me and said, I think you'd better put him in the side ward. He's got tetanus. And I'd completely missed the classical case of tetanus with a rigid mouth and unable to open his jaw, rigid abdomen, but it adds to one's life experience. The other case that's just come back to mind actually, when we admitted patients overnight, we usually had 5 or 6 new admissions, and we'd sort of clock them up and so on. And the following day, actually, I was going to be away because of my sister getting married or some such important family affairs. So I finished all these cases, and the last one I had come in for a gastrectomy. In those days, they were removing the whole stomach to treat peptic ulcers. And our professor of surgery actually was a very great enthusiast of these removals and operations, and so I took a history from this patient, examined him very carefully, and then it must have been about 4 in the morning, and I was just about finishing off, and then I felt what I thought was a lump in the abdomen, and I very carefully palpated it, and then I wrote in big letters at the bottom, query cancer of the pancreas, and left it at that. And then when I came back after the weekend, the registrar told me how pleased they were that I'd noted that, because in fact the patient was found to have a cancer of the pancreas, and he still had his stomach intact, which he would have lost otherwise if they just went ahead with the operation. So it's always important to do a full clinical examination under all circumstances, because the old dictum is if you don't notice things when they don't matter, you won't notice them when they do matter. So it's important to be a little bit sort of perfectionist. Well, of course, it now spans 60 years almost, that'll be next year, since I first came into contact with muscular dystrophy, of course, which changed my whole career, changed my whole direction, changed practically everything. And I think the main change, just looking overall, when I came into the area, I knew nothing about the disease. I'd never seen it before, and that stimulated me to go and look around the wards the following day at Queen Mary's Hospital for Children, where there were 2 wards with these boys with muscular dystrophy on long stay, because they had their schooling there as well. And so I was absolutely fascinated. And then I also noted that they had the most tremendous deformities, and many of them had a sort of S-shaped scoliosis of the spine. And it soon transpired that they'd only seen the doctor at one clinic, usually a neurologist, who told the parents, I'm sorry, he's got muscular dystrophy, there's absolutely nothing we can do, just make him comfortable. So these children were just left sitting in the corner, and they got total twisting of their feet and ankles, so that they couldn't even get into shoes, and they had muffs to put over in the winter to prevent the cold sores, and then they got the most terrible curvature of the spine. And so I felt sure there was something one could do, and it was fortunate at Queen Mary's actually that there'd been an epidemic of polio in 1956. Fortunate not for the patients, but fortunate for supportive treatment, because they had a number of children on ventilators. They also had a very active rehabilitation department, and they also had a very active program of preventing deformities. And one of the nursing staff actually was in charge of running a unit for making jackets for these children to prevent their curvature of the spine. And she had a brilliant idea of getting celluloid from a factory nearby, Queen Mary's, that had a lot of offcuts of celluloid they were using for other purposes, and this was then dissolved in acetone, painted onto muslin bandages which were wrapped about the child's chest, for example, and then it dried very hard and formed a nice lightweight jacket with very little cost. And in fact it proved very effective, that when these children stopped walking and the back was still straight, you could then put them into this and prevent it. And so the prevention of deformities, I think, was something very therapeutic for the children, and although it might have not been curative in the sense of disease, it made a big difference to their well-being. And I think this sort of attitude that there's no disease that's so bad you can't do something for the child or for the family is a very important pediatric principle.
Well, I suppose the thing that sort of catapulted me into cancer genetics was a very personal story, because my husband, being a gastroenterologist, he was looking after a young woman who had colon cancer, and he found out that she was, I think she was in her 40s or something, and she'd already had uterine cancer. And he came and mentioned it to me, just saying how odd this was. And he also said she looked a bit like my cousin, and he eventually talked to her, and it turned out that she was my cousin's wife's mother. And so at the time it really wasn't very well known about Lynch syndrome and that kind of thing, but I did know about Lynch syndrome, and I knew that Joan Slack was running a clinic at St Mark's Hospital where she assessed people's family histories and so on, and arranged screening if she thought that they were at an increased risk of colon cancer mainly. But she did also arrange gynecological screening for women in those Lynch, quote, Lynch syndrome families. Although the efficiency of that kind of screening really hadn't been established at all, although she had established a bit of the efficiency of efficacy rather of screening for colon cancer. So anyway, it took me rather a long time to screw up my courage to ring up my cousin's wife to talk to her about this, because I thought it was a bit intrusive, but eventually I did, and she was actually amazingly receptive. I remember exactly where I was sitting at the time. And so she agreed to go and see Joan Slack, and Joan said, oh yes, you probably ought to be screened. And so indeed she did start, she got put on the ladder for screening, but it turned out she was pregnant. So everything got put back by 9 months, so that all took rather a long time to get organised. And after she'd had the baby, it turned out that she had ovarian cancer, and tragically she died. So of course that was very, very shattering. And actually, if you can be sort of disconnect from what you feel about it, it was quite interesting. Later on we did see the whole family for genetic counselling, and it turned out that they had a huge family history of cancer, and nobody had ever sort of thought about it in terms of whether it meant that they were at increased risk or not. So that the sort of previous knowledge about the importance of family history of cancer hadn't really got above the surface.
So, I mean, thinking about my my achievements, one of my proudest of, I think it has to be the migraine one, and in many ways that's what people know me for. I mean, I was given the task of finding an anti-migraine drug, no clues, get on with it. So from nothing, I did discover this drug. I led a tremendous team I didn't. I think I did discover it because it was my idea, but it could never have been done without a tremendous team, and that included. Particularly, I've mentioned Basil Fennier, who was a close colleague of mine. I recruited him about 4 years into the project, and he made tremendous contributions, and many others. But I won't elaborate on that. But also chemists. The chemists were fantastic. Some of the clinicians I work with, we'd never have discovered that drug without the team. But I still feel that it was my baby. It was my idea without a doubt. And then along the road there were a number of issues. We found one drug that actually didn't do what I'd predicted on the basis of my hypothesis, and we had to go away and think again. And that was really because there were so many 5-HT receptor types that we hadn't appreciated. We were discovering them along the way. And then I think later on there were safety issues, worries about the drug being a vasoconstrictor and what other blood vessels might it constrict other than those that were involved in the migraine etiology. And you know, in many ways, I mean, I remember when the drug came on the market, people said, "You must be very, very pleased with yourself." And I said, "I will be in 5 years' time." 5 years' time, people said, "Oh, you must be very pleased with yourself." And I said, "I will be in another 5 years' time." And I must admit, I got really euphoric 10 years after it being on the market, because I think many of the safety issues had passed by, and I think the drug was being used sensibly in the right patients. And I still get letters from patients, and my wife kisses me every morning because her migraine's a lot better than it ever was, and so on and so on. So I'm very pleased with what I achieved.
But of course, the most important thing for us was that they would keep us up to date and trust us enough sometimes to tell us family secrets, like the existence of illegitimate children who were, of course, at risk of getting polyposis, and if not warned and treated or tested to find out if they were affected, the first time they might know about the condition was the development of cancer. So there were several occasions where we, through the social services or some of the religious organisations that dealt with adoptions, we were able to trace children that had been adopted. We would always write and say that we understood that a certain person had adopted a child. We didn't need to know where they were, we didn't need to know their name, but we would like them to reassure us that the child had been referred and screened. In dealing with the families, I don't think that I was always, in fact, usually not aware of how much they valued my involvement or my various colleagues' involvements in their care. Just a few years ago, I met a lady when I was going home from work. She was standing at the front door waiting for a taxi with her teenage son, and she greeted me with great pleasure and said, "Oh, Charlie, this is Kay. You have to meet Kay, because if you're ever in trouble, you just ring up and ask for Kay and she will sort everything out for you." And I had no idea that that was how she viewed me, and what, you know, the amount of well, I felt very little involvement in helping her during her time at the hospital, but obviously she viewed it differently, and that's very it's just very nice feeling to have that I have been helpful to people during it's a difficult condition to live with, and it's nice to know that I've helped. The most important change that's occurred during my time working with the families with polyposis, the various polyposis syndromes, is the advent of genetic testing. In the early 1990s, the APC gene was discovered, and the exact site of the mutations. Different families have different mutations, but the fact that we could, by 1996, we set up Robin Phillips set up an NHS genetic testing service with the Kennedy Galton Laboratory based at Northwick Park, and we were able to offer patients a genetic test. And I remember particularly one gentleman who had been coming every year for his examination of his colon to see if he'd got polyps. He was married but had refused to have children on the basis that they would be at risk of inheriting the disease. And when we were able to test him and reassure him that he had not got polyposis, his wife was still young enough that they could embark on having a baby. That's a marvellous advance to the scientists who did that work. Since then, the genes for the other syndromes have been discovered, and genetic testing and even prenatal diagnosis is now available for people who want it.
And my mother was a wonderful GP. She was very careful and very thoughtful. And when she went to Cardiff, there were only 4 women GPs in the city. So she didn't have a long time to wait before patients came to see her. She took me when I was a clinical medical student one night, when she was called at about 1 o'clock in the morning, to the upstairs room of a small side street house, a terraced house, where a woman had pulmonary edema. There my mother gave morphine, and the patient was left comfortable and quiet, and I saw excellent medicine in the context of the day done by my mother in the middle of the night, when she would have to get up and do the ordinary work of a GP the following morning at 9 o'clock. It was an example, and my father was a scholarly GP who studied books and kept on buying books throughout his life, annotated those books with the names of patients in the margins of his books.
So if I go back perhaps over to the 5-HT3 work we did that led to the development of anti-emetic drugs and I think revolutionised the care of cancer patients. You got to remember, I never saw these patients. I heard the stories of transformed lives and so on, and they were great. What I did see, though, at the time of an economic depression was the reality of the fact that that work created jobs. I saw teams of people coming in, both to lab work and development work. I saw nurses being employed. And I actually saw job creation, and that, for a long time, gave me the greatest pride. I could see that. People had jobs. And that's what industry it's not what it's about, but it's one of the factors of industry. It employs people, gives good careers, it should do. So that was one. Other achievements, always when you see a couple of ideas come together and you think, yeah, I got it right, that's a good moment. And they can be little things like the design of an assay to the eureka moment on getting the link between 5-HT3 and vomiting. There are lots of little achievements like that. I can remember great talks, I can remember bad talks. I can remember the pride at shaking Nobel Prize winners' hands. There are lots of special things. I remember some of the awards that were given. I remember in particular going to the Discoverers Award dinner run by Pharma in America. which I'd won a few years previously, and I went back. They invited me back to the dinner, as all past winners did. And at the dinner, all past winners were announced, and you stood up to have a clap. At the end of the dinner, the person running the whole show just breezed over, stormed over to me, and just gave me a mighty bear hug. As I stood up, I thought, what's this? He said, thank you so much. I've just come off a course of chemotherapy. I took these drugs, didn't vomit. Thank you so much. It was a very public bear hug, which was quite moving, yes, and have that on camera.
But to be in contact with patients does occasionally give you ideas, and I've got a couple of examples I could talk about. One was a patient who had a neurological complaint that no one had been able to diagnose. It was a mixture of various diseases, motor neuron disease, multiple sclerosis, and it looked like a number of different diseases, but no one had ever found out what it was. I was asked to see him by a lawyer, actually, because he was claiming for an industrial injury. And I realized that what no one had ever asked him was what his job was. And I went into some detail in his job, and he was being exposed to very high concentrations of organic chemicals. He was a painter, and he was painting in the military, and he was painting inside submarine tubes, the tubes for torpedoes. And he was exposed, we estimated his exposure, it was very high. And so I thought, I knew a lot about solvents and their effects on the brain, but there was a great deal of argument about whether solvents could actually cause serious brain damage, or perhaps cause things like multiple sclerosis or motor neuron disease. A lot of debate about that. And as a result of that, I managed to get a research grant to study all the painters in that workplace. And to cut a long story short, we found some very positive and interesting associations between solvent exposure and the neurological damage. That led eventually to a big grant, a European grant, to study chemical exposures in Parkinson's disease in 5 countries across Europe. That wouldn't have happened, and I had an early interest in neurology, which I was able to take up in the last decade of my career, doing epidemiology and neurology. It has now led to an interest in the environmental causes of dementia, which I'm pursuing with friends in my retirement. So that's one example. Another example was a patient I was asked to see after an operation on his chest. It collapsed, and there was this minor complication which I was able to help the surgeons sort out. And when he came round from his illness, recovered from his operation and the complications, turned out that the operation had been to remove something in his lung which happened to be pneumoconiosis rather than cancer, as they'd thought. Pneumoconiosis is a dust disease of coal miners. So I asked him what coal mine he worked in, and he said he didn't work in a coal mine, he worked in a shale mine. At the time, it was not known that shale mining, which was extinct actually, the industry had closed about 20 years before, but it wasn't known that it caused pneumoconiosis. So I burrowed around and found some more cases of pneumoconiosis in shale miners, and this was the time of the oil crisis in the 80s when the Arabs had put the price of oil up, and the Americans got very panicky and started exploiting shale in the Rocky Mountains. They wanted information on the hazards of shale mining, and I was able to get a grant from the US Department of Energy to study the effects of the shale mining on people in and around Edinburgh, which had been the centre of the shale mining industry from the 1850s up to the 1950s. So that was another example of a link between a patient and a research grant. So I've always been a believer in having someone in medical science who's actually in contact with patients.